Welcome and thank you for joining us for today's webinar brought to you by St. Louis College of Pharmacy's Alumni Association. My name is Stephanie Crist and I am an alumna from St. Louis College of Pharmacy, or better known as STILCAP. I completed 2 years of postdoctorate training with the University of Pittsburgh Medical Center, and I am a board-certified ambulatory care as well as a geriatric pharmacist. Currently, I am an assistant professor of pharmacy practice at STILCAP, and about 60% of my week is spent in direct patient care in a primary care medicine clinic. For the next 20 minutes, we'll review updates pertinent to pharmacists and the patients that we serve, specifically focusing on the influenza, pneumococcal, human papilloma virus, and measles, mumps, rubella vaccines. We'll wrap up with highlighting resources for pharmacists and new vaccines coming down the pipeline. If at any time you have any questions throughout, please don't hesitate to type them into the comment field in this webinar. A report from JAMA, the Journal of American Medical Association, published the week of November 29th regarding overall trends in mortality associated with infectious diseases, found some interesting statistics. So to orient you to this graph, on the y-axis, the data examines the mortality rate per 100,000 people, and on the x-axis is the year. The cause of death was captured from death certificates. From 1980 to 2014, infectious disease totaled only 5.4% of overall mortality. Per 100,000 people, infectious disease mortality increased from 42 to 63 in 1995, and this parallels the trends in the HIV/AIDS population mortality. And the decline since is associated with the use of antiretroviral therapy. Of the 5.4%, most of the infectious disease deaths, or roughly 40% between 1980 and 2014, were due to the influenza or the pneumonia. Overall mortality due to vaccine-preventable diseases declined, whereas the mortality due to pathogens with resistant strains remained stable. Trends in population subgroups in the community, such as measles outbreaks within low vaccination communities, were not captured. So the bottom line here is these trends illustrate that persons within the U.S. have continued vulnerability to infectious diseases that could be prevented. The National Health Interview Survey collects data annually, and vaccine coverage is an area that they highlight. The most recent data analysis is up to 2014. Highlighted are some shocking statistics for adults 19 years or older. On the positive side, there has roughly been a 3% increase to 20% of those patients receiving the tetanus with pertussis, or the Tdap vaccine, and a roughly 3.5% increase to 28% of 19 years or older receiving the herpes zoster or shingles vaccine. Areas that can be improved include 43% who are getting their annual influenza vaccine, 20% of adults less than 65 years with vulnerability to pneumonia are getting the pneumococcal vaccine, and in adults over the age of 65, just about 60% of them are receiving the pneumococcal vaccine. Most likely this is the Pneumovax, the PPSV23 vaccine, but may include some Prevnar or PCV13 vaccines too. Only 9% are getting vaccinated with the hepatitis A series, and almost 25% are receiving the hepatitis B series. Last but certainly not least, roughly 40% of females between the age of 19 to 26 years are receiving the human papilloma virus, or the HPV vaccine, and only 8% are males receiving this vaccine. As pharmacists, we can do a lot more to help increase these vaccination rates. And are you up to date with your own vaccines? First, we'll go over the influenza vaccine updates. So for the 2016-2017 influenza season that we are in the midst of, there is not a change in who should be receiving the annual influenza or the flu vaccine. So for all persons aged 6 months or older should be receiving the 2016-2017 flu shot. If you work within pediatrics or are vaccinating children, there is a two-step influenza vaccine series to complete for some children between the ages of 6 months and 8 years of age if they are receiving the influenza vaccine for the first time this season. I refer you to the CDC ACIP or ACIP guidelines for further details. New for the 2016-2017 season, the intranasal live attenuated product, known as FluMist, is not to be used in any persons as the coverage for this season's influenza strains did not show adequate response. For those needle haters, this product may be back in subsequent influenza seasons, but it is important to get the intramuscular injection product this year. I always tell my patients 5 seconds of getting a pinch is better than spending a week or more feeling ill. That may cause hospitalization or worse, death. Patients with mild to moderate egg allergies, for instance if they just have a rash or a hive reaction, or if they can eat egg products within cooked foods, they can get the trivalent or quadrivalent influenza vaccine products. Those with more severe egg allergies, such as those having an anaphylactic reaction to eggs, should receive the influenza vaccine in a medical setting and use either the FluBlock product if they are 18 years or older, or the FluCellVax product if they are 4 years old or older. Both of these products are made in non-egg containing environments, so there is not a risk of any sort of egg reaction. Medicare Part B and Medicaid plans, as well as all private insurance plans, cover the annual influenza vaccine. So that's good news. Pharmacists have probably encountered many patients who fear the flu shot, and they may say that it gives them the flu. This is just not true. All intramuscular influenza vaccine products are inactivated, so the most common adverse reactions are injection site reactions, such as redness, swelling, and tenderness, and these should not last but maybe a few days. Some patients may experience more systemic reactions, such as a fever or malaise. If they are diagnosed with the flu within the 2 weeks of receiving the vaccine, their body was already infected with the virus, as it takes roughly 14 days for the body to mount a response and immunity to the vaccine. And additionally, an article that was published in the JAMA Pediatrics on November 28th debunked the link of autism with the influenza vaccine. So be sure all pregnant women are getting their influenza vaccine during the flu shot season. I want to take a second and review some of the differences between the trivalent versus the quadrivalent influenza products, as I get a lot of questions in clinic, both from providers and patients. So the trivalent vaccine contains 2 influenza A strains, H3N2 and H1N1, as well as 1 influenza B strain, whereas the quadrivalent contains the same 2 influenza A and the 1 influenza B strain, as well as an additional influenza B strain. Why should the patient get the trivalent versus the quadrivalent? There's really no difference. Both are inactivated, attenuated vaccines, and there is no difference in safety. Most insurance covers either of the products. However, out-of-pocket costs are more expensive for the quadrivalent product. Pregnant women and patients with other immunocompromising conditions should receive either the trivalent or the quadrivalent. But I do want to point out that the FluBlock egg allergy product is trivalent, whereas the FluCellVax is quadrivalent. I also want to take a couple minutes to overview the high-dose influenza vaccine. So, for all patients over the age of 65 years, they should receive, or at a minimum, be offered the high-dose product. Both the Fluzone High Dose and new this season, the Fluad product are trivalent and inactivated. New data suggests that the Fluzone versus the Fluzone High Dose vaccine in older adults, 65 years, indicated for a high dose that the high dose was 24% more effective in preventing laboratory-confirmed flu cases. So the CDC ACIP recommends that this 2016-2017 influenza season, that all adults 65 years or older should receive the high-dose Fluzone product. There is a slightly higher risk for injection site reactions such as headache and malaise, but again, these are usually mild and temporary. And the idea with the high-dose influenza vaccine products is that as we age, our immune system is not able to mount as good of an immune response to the vaccine. And so these products contain a larger amount of antigen, and what that does is help boost the antibody response. Next, we'll move on to the pneumococcal vaccine products. There's really not a whole lot of new news. However, again, on a daily basis, I feel like there's a lot of confusion surrounding the difference between the Pneumovax and the Prevnar vaccine. So the Pneumovax, or the PPSV23, is an inactivated polysaccharide T-cell dependent vaccine, and it elicits a recall response following natural exposure or revaccination. The Prevnar, or PCV13, is also inactivated, but it's a conjugate vaccine, and it has limited duration of immunity. So over time, the immune response lessens following subsequent vaccinations. One vaccination of the PPSV23 and the PCV13 are recommended for all adults 65 years or older. This provides double coverage of certain strains, but in all, the patient is getting covered for a wide variety of some of the most common streptopneumococcal strains of the infection. So adults who are less than the age of 65, age 19 to 65 years, can receive either the PPSV23 or the PCV13 vaccines. For those who smoke cigarettes, have asthma, COPD, heart disease such as heart failure but not hypertension alone, liver disease including cirrhosis, kidney disease at any stage including dialysis, if they are a diabetic, are an alcoholic, have HIV or AIDS, any sort of cancer, or damaged or absent spleen, have cochlear implants, or have a cerebral spinal fluid leak, should receive one dose of the PPSV23. If they are more immunocompromised, such as with cancer, kidney disease, or have a damaged or absent spleen, cochlear implants, or a CSF leak, they can receive another dose of the PPSV 5 years after the first dose of the PPSV23. Those patients who are 19 years to 64 years of age can receive the PCV13 vaccine if they are more immunocompromised. So these patients include a damaged or absent spleen, have sickle cell disease, HIV, cochlear implants, CSF leaks, have chronic renal failure or nephrotic syndrome, have any sort of cancer, solid organ transplant, iatrogenic immunosuppression, even if they are on long-term systemic corticosteroids or are receiving radiation therapy, or if they have any congenital or acquired immunodeficiencies, such as B or T lymphocyte deficiency, should receive one dose of the PCV13 vaccine. This next sort of highlights the sequence of administration. So if a patient qualifies for PCV13, they should receive the PCV13 before the PPSV23, if both are recommended. If the PPSV23 is given first, then the patient must wait 12 months before the PCV13 can be administered. When the PCV13 vaccine is given first, you must wait 12 months before the PPSV23 vaccine can be administered, except if the patient has an immunocompromised condition, including a damaged absent spleen, CSF leak, and cochlear implant. Then you can give the PPSV23 vaccine 8 weeks after the PCV13 vaccine. Of note, Medicare Part B will cover one pneumococcal vaccine per 12 months. So if the patient qualifies for both the PCV13 and the PPSV23, you want to make sure that you're waiting at least 11 months in between those vaccine administrations. You should never administer the PPSV23 and the PCV13 at the same time. And like I stated a little bit ago, a patient can receive up to 2 doses of the PPSV23 before the age of 65, but these must be separated by at least 5 years, and those patients who have immunocompromising conditions. If a woman is pregnant, the safety data is unknown, especially for the PCV13, so the recommendation is to administer either before or after pregnancy. Next, we'll move on to the human papillomavirus, or the HPV vaccine. This vaccine is used for the prevention of vulvar or vaginal cancer as well as genital warts. There are currently 3 licensed products on the market. 2 of these 3 products are also licensed for males. So we have our most recent or newest to the market is the 9-valent recombinant vaccine called Gardasil 9. The other products, Gardasil and Cervarix, can be used in females, but only Gardasil or Gardasil 9 are licensed for males. This series is given in a 3-dose series. First, you receive your first dose at 0 month, and then 1 to 2 months after the first dose, and then 6 months is the third dose of the series. You can start administering this vaccine to both females and males aged 11 to 12 years of age, and you can receive this series up to the age of 26. There is some data that should be coming out in the coming months that talks about females receiving the HPV series after the age of 26 may also be appropriate, but as of right now, that recommendation is not backed by the CDC. It is not recommended that pregnant women receive the HPV series, and so again, if a patient is appropriate for this vaccine, you should wait until they are finished with their pregnancy or administer before they think they are becoming pregnant. It is important to note that a pregnancy test is not warranted before administering a dose. If you can, it's good to recommend patients get vaccinated while they are young, closer to the 11 to 12 years of age, but anytime before the age of 26, because this vaccine can be expensive, as each dose can cost upwards of $300. So for a 3-shot series, that's close to $1,000. I also wanted to take a second to highlight the measles outbreaks that we have been experiencing. There continues to be pockets of significant numbers of outbreaks throughout this country. Between January 2nd and November 5th of 2016, there's been a total of 62 people in 17 states who have reported positive for measles. The majority of these positive cases were unvaccinated. You are protected from the measles if you received undocumented 2 doses of measles-containing vaccine and are in grades kindergarten through the 12th grade, or you are an adult who has not been vaccinated as a child but is in a setting that poses high risk for measles transmission. Or if you have received and documented 1 dose, which is 93% effective, for those who are preschool-aged children or an adult who has not been vaccinated as a child, but it is in a setting that poses high risk for transmission. Or you could have lab confirmed positive for measles at some point in your life, or are immune to measles, especially if born before the year 1957. If you're unsure, you should find your documented records, have a lab-confirmed test, or get another dose of the measles, mumps, and rubella, or MMR vaccine. Right now, there is no booster shot that is necessary at this time, but you may be seeing an upward swing in patients receiving a 3rd dose in case they aren't sure of their history. There are many great resources for vaccines online, and I'm only highlighting a few here, but these are the ones that stand out. So the CDC and the ACIP recommendations can be found on the Centers for Disease Control and Prevention websites. They offer vaccine schedules for both pediatrics as well as adults. These are updated annually as well as continuously online if there's anything that comes out during the year. There's also a great safety vaccine website through the CDC, and I highly recommend you go here if your patients are asking any sort of safety-related questions. If you experience a patient who has an adverse reaction to receiving a vaccine, please report it. You can go to the vaccine reporting system through the government, and this helps us gather post hoc data for vaccines, and I think we overall underreport, so definitely be reporting if it's indicated. You can remain anonymous in your reporting. I've highlighted Missouri and Illinois state policy websites here, but each state has their own policies, and I recommend that you stay in tune with your state policies. And if you haven't already, look into recording the vaccinations your pharmacy or your clinic administers to the state vaccine registries. You can get there through the Immunization Action Coalition website. And lastly, some patients have a hard time affording these required or highly recommended vaccines. So to help with vaccine coverage, vaccine manufacturers often provide assistance through replenishment programs. So if you have a patient who is looking for assistance and they qualify, the manufacturer would just replenish the supply that you would be offering to that patient. You can start at needymeds.org, which is a great resource, even outside of vaccine products for any medicine. And it's always good to stay up to date as manufacturers are changing their requirements for who qualifies for patient assistance. And lastly, some vaccine pipeline information. So the first is the Zika virus and the vaccine. They've been studying in a preclinical study, 100% of the animal models were protected from Zika after vaccination, followed by a challenge with the Zika virus. So this is promising. In addition, they were the animal models were protected from degeneration in the brain, specifically in the cerebral cortex as well as the hippocampal areas. And the cohort that was not vaccinated showed degeneration of the brain after the Zika infection. So there's nothing in human testing out right now, but most likely in the future, if found safe, we'll have a possible vaccine for the Zika virus. Next is an HIV vaccine. There were some researchers who looked at the HIV population and those who had in animal models, not human models, but they looked at combining viral DNA with the virus, and they found that there was an improved viral suppression and delayed viral rebound following antiretroviral therapy. So nothing really significant from this as far as becoming more widespread in human use, but we could be seeing something down the road within the HIV population and prevention. And lastly, I found this one kind of interesting. As we all know, the prescription opioid epidemic is a real thing around our country, especially here in St. Louis. And they are looking at an oral vaccine that would essentially help decrease the abuse potential of prescription opioid products such as oxycodone and hydrocodone in patients who are using these products and might have a higher potential for abuse. So again, nothing on the market, but down the pipeline we could be seeing an oral opioid overdose vaccine product. So very interesting. I wanted to highlight here the college is hosting on Friday, January 13th, 2017 from 8 a.m. to 4 p.m. the APHA Pharmacy-Based Immunization Delivery Certificate Training Program. So if you're not already certified to vaccinate, I highly recommend, if you're local and in town, to register and come get trained. The APHA Immunization Center is also a great resource specifically for pharmacists and vaccine coverage. So that is it that I have. I've only covered a few highlights for our current vaccine recommendations, and I could really talk all day about these details, but the bottom line is that pharmacists are vaccinators and can infuse powerful change within our healthcare system, as we are one of the most readily available healthcare providers. So keep yourself updated, educate your patients, and get involved in your state and national level to help expand the pharmacist's scope of practice. Thank you for your time joining us today. Check out the Stillcap Alumni Association website at ce.stillcap.edu for upcoming webinars and other events.